So what are the drugs used for cord retraction? We do know that chemically impregnated cords offer better sulcus displacement, as you have seen, that it has both a mechanical and a chemical effect. If they are used for duration of less than 10 minutes, they cause minimal tissue damage. These chemicals can interfere with the surface detail of the impression and with the dentin surface. So thorough cleaning of the dentin is important before a resin bonded cement is recommended. Racemic epinephrine impregnated cord can cause elevated heart rate, blood pressure, especially if placed into bleeding tissues. So if you still choose to use them for some reason, it's better to use a 4% than 8% for cardiac patients. One study examined the effect of pre-soaked cords on the microcirculation of the tissue at the gingival margin and found that the blood perfusion fell markedly upon inserting the cord within the compounds. However, after 5 minutes, the decrease became less apparent with cords impregnated with aluminium chloride and ferrous sulfate. But the epinephrine soaked cords, they continued to affect the blood flow for the next 20 minutes. So these are the impregnated retraction cords that are available to us in the market. The gingibraid with aluminium potassium sulfate 10% and the epinephrine or alum. So they come as a combination as well. And it must be noted that the acidity of these agents, they are between 0.7 and 2. The pH is about 0.7 and 2. So they can remove the dentin smear layer and can cause post-operative sensitivity. So be sure to use like a cleansing and a desensitizing agent so that there is no post-operative sensitivity in the patient. So these are the impregnated retraction cords that are available for us. I'm sure you guys must have seen some of these, cords in your office, and there are just so many of them, and every doctor has their own favorite. So you guys will eventually figure out what works the best for all of you. And these are available in pre-cut lengths, and they have various sizes, and they have either epinephrine and alum or only alum. So basically it's good, you need to have both the options because some patients, they don't have any cardiac issues, but they are bleeding a lot. So then the epinephrine can be used on them more safely. But if the patient is, is not indicated for epinephrine, then you have the alum ready to go, So now we will talk about hemostasis. So if there is too much of bleeding, then you should not be using you should try to just reschedule the patient so that you can make your life easier, the patient's life easier. And sometimes even after trying to take the impression in the same appointment, especially when I recently graduated from dental school, I thought if the appointment is for crown, I have to make sure that, the impression is taken no matter what. But over time, I realized, no, it's important to take care of the patient's gingival health and the patient, sometimes it's too long an appointment. And towards the end, we are struggling, to take the impression and there's too much bleeding. So it's always a good idea to let them know that we are doing it for their best. And sometimes even the patients have a time crunch, they're traveling, but it's important to let them know that we are doing it for them. And they will appreciate that towards the end. Because the main thing is that we have to get a good final product. So, and it seems that most of the dentists and assistants as well, they prefer using the pre-soak cords because, it's convenient. Otherwise you have to cut. Then I've done that before. Soak it, make sure it's not too much. So dry it with the cotton roll or gauze and then place it. And of course, the ease in placement is also easier if it's pre-soaked because they know it's just the right amount of chemical, it's not too much or too less. So just to review, these are the hemostatic agents, the impregnated cords. They have alum, aluminium potassium sulfate, or racemic epinephrine, or both. And aluminium chloride solution and ferric sulfate solution is also available to us, which have the similar properties of the other agents. Impregnated cords, for example, unibraid. So they combine the chemical action as well as tissue displacement. And what does alum do? It basically is an astringent that it causes the contraction of the tissues, and it's styptic, which means it causes surface coagulation. So it works in two ways to help with the control of bleeding. And epinephrine, what epinephrine does is it constricts the blood vessels, especially the microcapillaries, but it's still like controversial. That means, of course, if it's contraindicated, you would not use it, right? So I think that's the controversial factor. But I know that for a fact that if, you're going to need more working time, then epinephrine tends to make the tissue less bleed for like longer time. But to be honest, how much time do you actually need after packing cord? You just need to take the impression, and so it's basically your call. But it's not that people don't use epinephrine. I've used it several times, even just where I've tried to control the bleeding and it's not working out. So even like using a syringe which has, like basically a local anesthetic with maybe a little bit higher concentration, like 1:50,000 for epinephrine, like lidocaine with epinephrine, and use that in the gingiva, basically in the gingiva between the two teeth. So like in the interdental papilla, I've used that to kind of help with the bleeding if the patient has been bleeding too much and I've had to take the impression on the same day. So that actually works pretty well. So it's a good thing to know. I mean, you maybe you cannot give the anesthetic, but your dentist can, but you can request them to do that if you feel like the bleeding is too much. So control bleeding first. That is going to be a no-brainer. Like, it will make your life so much simpler. That always remember that you have to make sure that the bleeding is controlled. Okay, so what is aluminium chloride? The example, or like the products that we use which have aluminium chloride are Hemodent and Nephrostat. So aluminium chloride is used in the form of a buffered solution which has 25% aluminium chloride. It has, again, astringent and styptic effects, as we saw in alum as well. And it's used to, so basically, if you want to increase the efficacy, make sure you saturate the impregnated cord. So I think Hemodent is one of like the first chemicals before viscostat and everything that I use, that, it comes in a small bottle, it has liquid, you pour it on a dappen dish, and then you can saturate, and then if it's too much, then you have to just dry it off a little bit and then use it. So, and it has a dual action. It has simultaneous hemorrhage control, so it stops the bleeding and it helps displace the tissues to get a good impression. Ferric sulfate, this is viscostat. It is a viscous solution of 20% of ferric sulfate. So you've seen the consistency of viscostat. It's more like a gelish form, and versus the Hemodent is like a liquid. And this is a very potent coagulator, and it's very effective. I think this is one of my favorite materials to use when there is bleeding. So I use a cotton cap and I put the viscostat in it. I have the patient bite down. I give them like 5 to 7 minutes for it to take effect, and it's pretty much like once you're done, you just wash out the viscostat, and it's a pretty good controlled field. And then in this case, the hemorrhage control and the tissue displacement is performed separately, whereas in aluminium chloride, it was doing it together. And what are the different ways that it's available in? There is unit dose syringe, then there is a Dento infuser syringe tip. That's the one that I've seen most often. And you have it in the form of a cord, which is a non-impregnated knitted cord. So ferric sulfate, example viscostat, that is also the similar compound. And there is a disposable tip. So that's how you make sure, it's safe to use between patients. So you have to dispose the tip off, and then you can use a new tip for a new patient. And it's either applied around the tissue, or I sometimes tend to put like more amount of it, put it on a cotton cap and have the patient bite down. And then this controls the bleeding, but the only thing is that it'll leave a residue on the tooth and the tissue, so it needs to be completely well rinsed off before we proceed. So ferric sulfate, viscostat, it's similar slide, so it's just a revision. Viscous solution of 20%, put in coagulator, and performs hemorrhage control and tissue displacement separately. And it must be used with other system components. It's a unit dose syringe, dental infuser syringe tip, and ultra pack cord. It's pretty much the same slide we did 2 minutes ago. Okay, so this is a slide which is pretty useful for you guys, even for like when you're studying for the exam, because it has a comparison of the tissue management techniques. So on one side, we have the impregnated cord with aluminum chloride, and on the other side, we have our viscostat system. So again, we have been saying this point, but I'll repeat it once more. In this case, you have simultaneous hemorrhage control and tissue retraction, whereas in this case, first the hemostasis occurs and then the retraction. And then in this case, you have to place the saturated impregnated cord for 10 minutes. And sorry, this slide needs to be a little bit edited. I'll make sure it's done in the final when I give them to you. But it's basically the saturated impregnated cord is placed for 10 minutes. And then you have to remove the cord, inspect and proceed with the impression, or repack if it is required. Whereas in case of the viscostat system, you have to rub it in, then you rinse, then you inspect if everything is okay. If the bleeding is still there, then you have to repeat it. And then you place a moistened cord. And then you remove the cord and inspect and proceed with the impression. If viscostat is, or if viscostat is necessary, then you repeat the process. Okay. So retraction cord placement. Make sure you're as gentle as possible. Of course, it's gingiva. It's literally like you're pushing on somebody's skin. So you have to be as careful as you possibly can with it. So you have to keep the cord between the packing instrument and tissue. So, you'll get a hang of it once you start doing it, but typically I try to pre-cut it to the approximate size that I think that it'll need. It takes a little bit of time to figure out, I'll always go in the side of more than less, because if I'm doing less, then I have to remove the cord and redo it again. If it's more, then, the scissors are pretty effective, that you don't need to take anything out. You can just cut a small slice, and that's about it. So, and then you have to angle the instrument so that you slide the cord. So basically, just imagine if you have to tuck in something, that's the angle. So you want to hold the instrument, and you don't want to put pressure vertically down, but like kind of like slip things in, right? So angle the instrument, slide the cord along the tooth into the sulcus. And of course, if the cord is big or the gingival tissue is really healthy, the cord tends to come out. So you just have to hold it in slowly. Don't put more pressure. Just gently maintain the gentle pressure. Or if you feel like it's rebounding a lot, or every single time you're trying to push it in, it's happening, then go for a smaller size. Okay. So what are the retraction cord techniques available to us? We have 1 cord and 2 cord technique. So they both have indications. As far as possible, try to do 2 cord technique. It always gives you a better impression. The main thing that the bottom line is that you have to control the environment. Okay, so place the cord atraumatically. Of course, that's something that you will always have to remember whenever you're doing any retraction cord placement. And again, keep the cord between packing instrument and tissue, And I'm sorry, the slide just repeated, so I'm going to go ahead. Okay, so this diagram is very good because it explains where exactly we need to place the cord and where the impression material needs to come. So this is the finish line, right? And this is the emergence profile. So basically, when the lab is designing your crown, they really need to get this point recorded, because that's how they're going to determine the contour of the crown. So you must have seen in some cases, I think I've seen it more in implant crowns versus regular crowns, where if it's like a bulbous crown or it's a little bit shallow, they'll both cause problems. This will cause gingival problems because it'll be coming interfering in the way of the gingiva. And in this case, sometimes it'll be an under contoured, so more reason for the bacteria to stay in. So make sure that you're making a good retraction cord. Okay, so the tissue retraction technique. So we'll go over the steps. First, of course, nowadays, because of COVID is going on, you're going to do a temperature check, a symptom check for COVID. But once everything is okay, patient is seated, we check the blood pressure, patient's medical history, if they have any hypertension, cardiovascular disease, or they're taking any medications that are contraindicated with epinephrine. So if the BP is within normal limits, everything is okay, we go ahead with the anesthesia, we take the preliminary impression. So make sure you never forget that, because otherwise, and especially if you do it once, you will never repeat that, because you have to use the pre-formed crowns, which is not fun to do. And I really like the way, because basically if the tooth is a little deformed, or in the patient's model it's a little rotated, when you have the preliminary impressions, you just basically are replacing that crown or tooth form back, so the patient doesn't feel like it's something different. So whoever developed this technique was like a really smart person, and it makes a really good temporary. So make sure you take the preliminary impression, and then the doctor will complete the crown preparation. After that, we have to fabricate a smooth, precise fitting temporary. I cannot stress enough, how important this is for the gum tissue health and for the comfort of the patient. Say if the patient is uncomfortable for the 2 weeks that he had the temporary crown, I'm pretty sure he's not going to forget that, like it's something that he's going to be using. Sometimes it's longer than 2 weeks. You don't know, patient scheduling is a problem, or something can happen. So you should at least be prepared that if the crown has to stay in the mouth for 4 to 6 weeks, it should be a good quality temporary. So and then after that, you have to so the process of doing the temporary, it's better to do it before you take impression, because it gives you a sense of like, is there any place where it's under reduced to kind of go back and do it. So it's better to do it before you take the impression. So if you take a temporary and you see there's light shining through a particular area, it's too thin. Sometimes it's on the occlusal, that is like a no, but sometimes it's also like lingual or buccal surface. So it gives you a good sense that okay, I should do a little bit more reduction. So in that case, you just show it to the doctor and he can go ahead and proceed if there need to be any changes. And then, if there's a situation where you cannot complete the crown impression that same day, there could be a variety of reasons for that. So in that case, you can just kind of, you have the temporary ready to go, that, you just put it on the patient and he's done. So when the temporary is done, you have to start with making sure that you have a dry field. So a lot of basically air syringe, and if the isolite is there, then like just have it run for a few more seconds, and then of course after the cord packing you have to take it out. But isolite does a really good job to keeping the saliva of the tooth and gums. So then you start with packing the cord, and usually I start on the mesiobuccal line angle and go towards the lingual distal and then buckle, or sometimes I go the other way around, just depending on which side the tooth is in better axis. And then leave it in place for 5 to 10 minutes. I usually do like 3 to 5 minutes, but you can do it for a little bit longer if it's needed. Keep the cord virtually dry, but it has to be slightly moist. So if it's completely dry, what will happen is when you pull the cord out, it's going to start bleeding. So the entire purpose of placing the cord is going to be wasted. And then if there is no bleeding, then you can remove the cord. And this time you have to be really prepared. So somebody has to be ready with the placing the light body, heavy body into the tray, and try the tray in before you start doing this. So you have your path of placement, everything ready. And sometimes it's good to, like, especially I think the most important thing to take care of is that the patient doesn't bite into the tray. So, I mean, it's pretty easy to figure that out, but like say you have to take a first molar, second premolar impression, make sure it's a little bit of longer double bite tray. And then I try to remember, okay, so this part of the tray is ending at this part of my, like maybe just before the first premolar or the middle of the first premolar. So then I have like a landmark just to make sure that I'm making the, I'm not wasting the impression just because I haven't placed it right. That's, there should be a lot different reasons if you have to redo the impression, I think. So yeah, so let me see, where was I? And yeah, if you feel like the area is too dry, just take a small cotton pellet, fill a little bit amount of water, and put a little bit of moisture before you remove the cord. So once the cord is removed, the retraction is maintained for about 30 seconds. So be prepared to immediately start syringing your impression material. If the bleeding is persistent when the first cord is removed, go ahead and make the impression anyway, knowing that it won't be acceptable. Don't even look at it. But it will maintain the gingival retraction and give hemostasis. So once you remove it, immediately take a second impression, as the sulcus will be open and the bleeding would have been gone with the help of the first impression. By the time it takes to set, you have the, the bleeding is stopped. So it does take more time and expense to do the double cord technique, but it's worth its time. And it'll, like, when you get that really good impression and you're sending it to the, like there are times where I've taken the impression, I was like, I hope it works, and I send it to the lab. So I'd rather take that longer time, and then I'm more confident that, okay, I won't have to have the patient come again with the whole crown, So of course, if you compare that, maybe the crown is not a good fit, the margins are not fitting. So now you have to tell the patient the crown is not good. So then you take another impression. Better to just pack 2 cords and then be done with it, So yeah. And then let's see. There are some clinicians that would prefer to place the retraction cord before finishing the preparation, so they can actually get a better view of the margin. I'm not the biggest fan of this procedure because sometimes the cord just comes off with the burr. So, I feel like, okay, now I have to retract it again. But if there are cases where I really need to see, then I don't mind spending that extra time doing the retraction cord. Even if it comes out, then I'll just place another one. Okay. And there's an alternate technique in which you leave just 1 cord in the sulcus instead of 2. And in this case, there's more retraction, and the cord is there's a little bit of lesser retraction actually, and the cord is often on the finish line. So in this, I pretty much use 1 cord if I feel like it'll give me enough space. Sometimes my margins are not as subgingival, it's almost just at the gingiva, a little bit supragingival. In that case, I'm okay to pack 1 cord. And you have to make sure that there's at least 0.5 millimeter below the finish line, especially where there is or in cases where there is thin gingiva. That's when I would prefer using 1 cord versus 2 cords. So then you have to remove and inspect the impression. Typically, I leave it in for 5.5 to 6 minutes just to make sure that it also depends. That completely depends on the impression material. I pretty much use it maybe like 30 to 60 seconds more than the recommended time. But yeah, nowadays there are impressions that set in 3 minutes. So then maybe just keep it for 4 minutes. So and then if there are any cotton rolls on the border of the impression, you have to take them out and disinfect the impression before you send it to the lab. Okay, so next slide. Okay. So what are the cord packing instruments that are available to us? We have the flat end, we have the round serrated and the non-serrated. So make sure that the end of the cord packer, it needs to be thin enough to be placed in the gingival sulcus without damaging the tissue and causing any bleeding. The angulation of the instrument will help with the orientation for the placement. And many clinicians find that placing cord with a non-serrated instrument is easier as the cord will not pull back out of the sulcus. And the design of the instrument is obviously limited to the manufacturer. You can't say that I want to custom make a, but in these, like these days, all the quality is pretty good. And, you know, if the cord packer is not thin enough and it's not going to function at all. So you get pretty good quality instrument from most manufacturers. And then it also, you know, like for anterior teeth, the flat instruments actually work pretty well. And for posterior teeth, the rounder, serrated, non-serrated work better. But, you know, you guys will get, you know, you'll have your own favorite instruments. In fact, I know if, you know, even though if I have a couple of sets, there's like one set where I like, oh, I really like that. But, you know, you just get used to it too. So something that you'll figure out over time. Okay. Let me see, where was my slide? Okay. Okay. So there is cordless retraction as well, where cordless retraction, and basically they deflect the tissue and control hemorrhage and moisture. So they come in a syringe form. I personally haven't used them as much, but I know people who do, they really swear by it. So that's something that you guys can try. But, you know, if you have deep subgingival margins, then these products don't work as effectively. And also depends on what your doctor prefers. If this product is something that he really likes, then I think the variety that are available are Expasil, Traxodent, and Gingitrac are probably the most popular ones. And they are made from a viscous paste of diatomaceous clay with aluminium chloride, and they require 2 minutes in the sulcus. They give excellent gingival retraction that is non-traumatic and non-invasive. When used with a compression cap, they enhance the effects of the material, and they can be used alone or with a retraction cord. Okay. So in this diagram, you can see that the cord packer is pushing the cord along the side of the tooth, and it's not even touching the tissue. You're just sliding the cord in against the tooth. So you have to put pressure against the tooth, not the tissue. And the tissue will be displaced laterally when the attachment is unchanged. So this is a really important point. The tissue will be replaced laterally. Okay. And how is the cord packed? How is it done? Firstly, there is no one size fits all. You have to evaluate the health of gingiva and the depth of the sulcus. Select a diameter that looks like it will fit. If there is a minimum sulcus depth, it will only accommodate a single cord technique and probably only a thin cord. So that will be a case by case decision. And over time, you guys will get a good sense of judgment that like I've seen some doctors, they use like a set formula, like for the first cord 000 and second cord would be like a 0 or 1. I really like to just evaluate and look at the, you know, like with the gingiva, like even the probing depth helps. Like if it's 1 to 2 millimeter versus 3 and more, Then, of course, if it's a larger sulcus, you'll use a bigger cord. If it's a smaller sulcus, you don't want to. Basically, the most important thing that you have to remember in cord tissue retraction, of course, is to get the reason why we are doing it, get a dry field, but also to maintain the gingival health. You just have to really keep that in mind at all times. And there's no point of doing the crown, and first thing is do no harm, right? So just please take care of the gingiva. And so the cord is gently packed in the sulcus, pressure is towards the tooth, and then a portion of the cord is already tucked in. Leave one end out for access in removing the cord for impression, and the overlap is in the interproximal area. Okay. So a deeper sulcus with healthy tissue accommodates a double cord technique. The thin is done first, and the second one is a bigger diameter. So the initial thinner cord controls any bleeding from the base of the sulcus. The cord works mechanically, but the astringent has the function of blocking sulcular secretion and hemorrhaging. So twist the first cord very lightly and loop it around the preparation. Overlap slightly, gentle, tuck it down beneath the shoulder of the prep. The cord will unwind a little bit, but force the tissue laterally away from the tooth. Next is twist the second cord tightly. Repeat the process again. If the cord unwinds slightly, then push the tissue laterally. Leave the cord in 5 to 7 minutes. Okay, and now we're going to go ahead and see a video that will talk, that'll review everything that we talked about.
Place gently, but with sufficient firmness to place the cord just apical to the margin. Not only overpacking should be avoided, because while performing this technique, it is very important to remember some key points to avoid damaging the soft tissues. Tissue must be displaced gently, but with sufficient firmness to place the cord just apical to the margin. Not only overpacking should be avoided, because it could cause tearing of the gingival attachment, but repeated use of the retraction cord in the sulcus also should be avoided. Both can create some gingival recession. It is also recommended to start on the interproximal area, where it's easier to start packing the cord. This will bother less the soft tissues. These two pictures represent how far we should pack the retraction cord into the sulcus for the double cord technique and the single cord technique. It is important to remember that the sulcus, after being displaced, forms a V shape. That's the reason why we pack the smaller diameter cord first and then the larger diameter cord. Notice that the retraction cords have been packed within the sulcus. This way, we don't bother the gingival attachment and prevent any gingival recession. Currently, in the clinic, we use the Ultra Pack retraction cord, which it is fabricated by the company Ultradent. This is a 100% cotton, plain knitted retraction cord. Each clinical case should be evaluated independently for the selection of the appropriate retraction cord. One of the things that we need to pay attention is at the position of the preparation finish line. Clearly, if we have a supragingival margin, we don't need to retract any tissue. But if we have an epigingival or subgingival margin, then we need to evaluate and decide how much tissue we need to displace. The gingival sulcus depth should also be evaluated by gently probing. This way, we will be able to determine if we can pack 1 or 2 cords. And last, the gingival biotype, which means how thick is the gingiva around the tooth. Sometimes when we have a thicker biotype, it is more challenging to displace the tissue. Therefore, we need to select a larger diameter retraction cord. This picture shows us how the second cord should look after being placed. It is important to be able to see it in order for it to guarantee us that the soft tissue won't be in contact with the margin during the final impression. If you did the appropriate technique, you should get an impression of the tooth similar to this, where you can see clearly the finish line and some extra material that went down inside the gingival sulcus. The following are some clinical examples where the technique was done appropriately. This way we were able to impress the finish lines very nice and got excellent results. To finish this overview, I did a small video with the appropriate technique on how to pack cord on a premolar. In this case, I used the 0 and 00 cords. We're gonna start by cutting the retraction cord. For this, we're gonna open the container and we're gonna notice that it has a blade on the inside, which will facilitate cutting the retraction cord. We're gonna pull it out and cut the amount needed. Close the container. That was the first cord, the 00, and then for the 0 cord, which is the second cord, we're gonna pull out a little bit more. We want to have a longer cord since we're gonna have a tail that will help us when making the final impression. Then we're gonna take a small plastic cup and we're gonna place just a few drops of Hemodent. Just as an overview, the Hemodent is a hemostatic solution composed of aluminum chloride. It contains no epinephrine, which helps to avoid tachycardia during this kind of procedures. It is very stable, offers a long shelf life, and it is used for this kind of procedures to control bleeding and other exudates coming from the sulcus. It can be also used for other kind of procedures, like when you're doing the actual crown preparation. It can also be used when doing composite restorations. This will help us keep the dental structure drier and achieve better bonding. Can also be used when cementing restorations and on any other kind of periodontal procedures. So we're gonna place just a few drops of Hemodent on a plastic cup, and then the retraction cords inside. We're gonna soak them completely. Then we're gonna take them out, and I like stretching them out and having them placed on a napkin or a gauze so that it absorbs most of the Hemodent. By stretching it out, it will make it easier to pack on the sulcus. And we can notice here where the second cord is longer than the first one. That will help us with that tail that we need for the impression. Now we're gonna start with the packing. Remember that there are special instruments designed for this kind of procedure. We have the serrated and non-serrated instruments. Either one will work fine, and you just need to make sure that you have it on your kit, on your cassette, and use it appropriately. We're gonna start packing the cord, and as I stated before on a previous slide, it's easier to start on the interproximal area. So we're gonna start packing one of the ends of the cord, and then once we get that in, it's easier to move along and continue with the rest of it. Just gonna continue packing it very gently, very slowly. We're gonna continue, and when we're getting closer to where we started, we want to make sure that we don't have extra material. Remember that we want the two ends of the cord meet each other perfectly. So we can see right over there, that's where we started packing that cord. So we're gonna take some scissors and we're gonna cut that extra cord that we don't really need. And then we're gonna finish packing it, making sure that those two ends meet each other.
Sorry, just give me a quick second.